So just before we start this episode, I've got another podcast just to recommend to everyone. It's called the TAC Medic Whiskey Podcast. It's a podcast for up-to-date information on everything tactical medicine and indeed pre-hospital medicine. So the host, Steve Wood, who is a colleague and friend of mine, explores the life-saving techniques, real-world experiences and indeed strategies for handling high-pressure situations. So whether you're a seasoned professional, an aspiring tactical medic, or just curious about this field of care, this podcast offers expert insights, practical tips and stories from the front line. Just head over to the show notes to find a link to the TAC Medic Whiskey Podcast. Welcome back to the podcast. Just before we start this episode, it's just worth saying that my podcast microphone actually died before this interview, so I've managed to get a new one, but just to let you know that the microphone and indeed the sound quality on my side didn't sound particularly great in this interview. Claire's was nice and sharp, but mine was recorded on a headset. But that doesn't detract from the quality of the interview, indeed the quality of Claire's answers, and indeed the quality of the content that she conveys in the interview. So please do bear that in mind, that the quality of the interview definitely outshines the audio quality on my side. But listen, thanks for your engagement and your time. This is a fantastic interview on educating high-performing teams from the director of Sydney HEMS with Clare Richmond. Please do enjoy.
You're listening to the Pre-Hospital Care Podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, I'm going to be speaking with Clare Richmond around educating high-performing teams. So in this episode, we're going to examine the fundamentals of training and educating high-performing teams in education. So we're going to look at some of the real-world scenarios, high-fidelity situations and simulations to better prepare trainees. We're also going to discuss the role of high-fidelity simulation in enhancing learning experiences using the metrics to evaluate training effectiveness. We're also going to share strategies for continual improvement and look at training programs and how we continually improve those. And then we're going to also look at some take-home points on harnessing some of those crucial 1% improvements in training. So to do this, we have Clare Richmond with us. Clare is a retrieval specialist and indeed the director of emergency medicine training at Sydney HEMS. She serves as a State Retrieval Consultant for New South Wales Ambulance and as an Emergency Physician VMO at Royal Prince Alfred and Canterbury hospitals. She is a graduate of Sydney University and trained in emergency medicine at Royal Prince Alfred Hospital and completed a fellowship at Sydney Clinical Skills Simulation Centre. She's also taught and worked in PHEM in diverse locations, including Sydney, Alice Springs, and London. Welcome, Clare, to the podcast.
Thanks for having me.
It's great to have you on. Clare, I just wondered if you could just maybe unpack your background, but also roles, and indeed what you've kind of maybe some of the seminal things you've brought forward into your current role from some of your previous experience across the world.
Yeah, so I guess I accidentally fell into medicine, having worked in hospitality for a few years, and decided that after doing a science degree that emergency medicine was for me. In part because I had the attention span of a flea, but also because I really felt there was some value in looking after patients there in that emergency department and their sickest days. When I was training in emergency medicine, my next door neighbours were both actually working on the rescue helicopter in Sydney, getting on their motorbikes and riding off to their shifts and coming back with incredible stories. And so that made me think about a career in retrieval medicine, which I don't think I would necessarily have thought of as early on as I did without those two girls who were working there. And then that led me through emergency medicine training. Of course, always with the diversions at times going, oh, maybe I should do neonatology, maybe I should do geriatrics. And I think for those that know me, they would very much agree that I've ended up in the right place. So now I have taken on board all of the experiences I've had. I did retrieval and pre-hospital medicine in Sydney. And after I finished my emergency medicine training, I decided that to complement that retrieval experience in Sydney, I would go to what's probably one of the most different places in Australia to work, which is Central Australia. So working out of Alice Springs, mainly on fixed wing, going to pick up patients all over that middle part of Australia. And the funny thing about working there, or the interesting thing about working there really, is that there aren't really many other hospitals there. And certainly when I did that in 2011, 2012, I arrived in Tennant Creek, small hospital, to find the locum doctor there for the week was the radiology registrar that I'd worked with at RPA, who who knows when he last put in a cannula. And there we are dealing with some really sick patients with flight nurses and lengthy transports. That hospital, knowing I've worked with you in London, that's 600 kilometres away from Alice Springs. So just a short distance to travel. So from London, from Alice Springs, I then went to London and worked where the admissions are short, sharp, predominantly trauma-based, and really has a different pathophysiology of disease. Well, you're at least getting to patients that are very different pathophysiology of disease than you are in both Central Australia and also in many respects in New South Wales as well. I came back to Sydney for a consultant post. And my first mission back in Sydney was actually 16 hours from start to finish, which very different from inside the M25 in London for a trauma patient. So different. And I think I've basically taken all of those different experiences in order to apply those where I'm working now in pre-hospital and retrieval medicine. And it gives me a real insight, I think, into retrieval and the different environments that you can work in. And alongside those retrieval posts, I've done some emergency medicine in some regional areas, as well as in central urban trauma centres. And so I really think I've got a bit of an understanding about what happens in those different environments there.
So Claire, could you speak to your time at the Clinical Skills and Simulation Centre in Sydney? Because I think as part of your journey, I've spent a little bit of time in various clinical skills and simulation centres and realised the adage and the benefit of just incremental improvements in both the fidelity, but also the debrief, and bringing teams through some of the commonalities that teams struggle with. And could I get you to speak to that as part of your journey to Sydney HEMS as the Director of Education, and what you sort of brought forward from that experience?
So I actually did my SIM fellowship simultaneously with working at Sydney HEMS in 2011. So I was half-time retrieval and half-time in that education role, which I think was a really nice place to be because it allowed me to work in those things, in those environments in parallel. And I was really fortunate when I was working for the SIM Centre there, and I still do some work for them, to work alongside some fabulous nurses and also some other emergency medicine specialists and anaesthetists who spent time with me teaching me about how to debrief, looking at the language that we use, really working on how you listen to people, and also making sure that we spent a lot of time debriefing the debrief to see if we could actually help people to dive deeper. And I think one of the biggest things from a debriefing point of view is we spend our time talking about what happened in that sim rather than what we apply and can take from that sim to apply at a later date. And that's so valuable and so important because you're never going to encounter that simulation again. But what you will do is be able to take the pieces of learning from those environments and actually use them and apply them wherever you happen to be, whether that is in hospital or out of hospital. So I was really lucky to have that experience, and it taught me the value of interdisciplinary learning. So we would have people of different grades, but also doctors and nurses were the primary people that we had, and we loved having different people in the room when we were who were training together. And when we did that, we always made sure we had a doctor and a nurse doing the debrief if there were a doctor and a nurse as participants. And we really do work our way to continue that in Sydney HEMS, and it's one of the things I'm really clear about. Having continued to work with them through debriefing and developing my skills, we really started to unpack some of the minutiae of how you debrief. So giving ourselves a structured approach, and we've got a really clear structure at Sydney HEMS as to how we go through the cycles of debriefing. So opening, reflecting, and doing that through the learning objectives that you have before summing it up and closing. Knowing that every time you run a sim, there's plenty to talk about, but if you can design a sim to actually reach learning goals, then you can actually make sure you cover those things. And we make sure that that's part of a big curriculum, that all of the things actually come through, but over the course of our training program, but also so that your learners, whether they are active participants or active observers, all come away with solid learning points from the sim that you can really quantify.
So could I get you to speak to your current role, Claire? Because, you know, as a director of emergency medicine training, I'm sure that there is a real the stewardship of the running of these training courses, but there's also a semblance of seeing that over time in iterations in your approach, seeing different teams coming through, taking, like you said, high performing debrief as part of high performing training, and just if you could just maybe unpack the different facets of the role and how, I guess, really how it's changed you over time.
So when I came back to Sydney HAMS, I was part of the training team. I worked alongside Cliff Reed, who I know that you know, and everyone probably knows quite well. And we worked together to develop the training program, and we added on more days, we added on more components. And in fact, we ended up ultimately flipping the weeks around, knowing that from our training program, when we get new registrars, we're taking doctors who have mainly worked really solidly in hospital. Of course, some come with pre-hospital experience, and we're taking the skills they've got there and translating them into their skills that they can bring to treat patients in the pre-hospital and retrieval medicine environment. And they're doing that pretty quickly in that they're not supervised. We don't have a 3-person team. They're working alongside critical care paramedics and our flight nurses fairly quickly. We have taken the program from doctor training program to medical team training. And I think that is the basis of what we do. The team is the doctor and the paramedic, or the doctor and the nurse, who work through a function of shared leadership to treat the patients that they're looking after. And we do simulations for that. And when we do sims with our teams, they are working alongside. When we do the inter-hospital sims, they will go in and treat patients, where they walk into the room and they will find live patients most commonly. And the team looking after them will be doctors and nurses who they probably have not met before, actually treating those patients and providing the care. So it's really, the human interaction is a huge part of the fidelity that we would have there. For the pre-hospital sims that we do, we're really fortunate to have paramedic students who come along and help us. Those paramedic students role play the bystanders and the patients in our pre-hospital sims. And then New South Wales Ambulance paramedics come in to be New South Wales Ambulance paramedics in the simulations. And our trainees arrive as doctor paramedic teams to treat patients who are working along, and they're working alongside those New South Wales Ambulance paramedics. And they really do start to get to know each other. The fundamental thing that I think we've added to that is that we make sure that those other people who are working alongside them come into the debrief, and they actually provide feedback to our trainees about how they're working alongside them, the human factors components, how they're delegating tasks, how they're working together to look after that patient that is there.
So Claire, looking at so one of the things I wanted to say before, but I kind of held back on, was one of the things I realized about debrief is that absolutely, to your point around, it has to align with the ILOs, the intended learning outcomes for the situation. But one of the meta themes I realized from a deep psychological perspective was around getting the best out of people. And teams and high performing teams sometimes it's not always just about reviewing the failures or indeed the challenges. It's also about the affirmation of what, and it's also super important about putting the affirmation about what they did well initially, so that there's a review of and an acknowledgement of what the team has done well, but also on the back end of that, and it's a nice segue, and it always should really be successes / things done well, then challenges, and then, like you said, aligned to the intended learning outcomes. But the meta theme is really celebrate the wins, and don't negate the wins, but then look at the challenges, and like you say, get the reflections from the whole team and some of the challenges from outside of the team.
It's interesting you say that, because when I first was getting involved in SIMS, I was watching people who were running scenarios outside of the SIM Centre, because I think this is something that I definitely learned from people at the SIM Centre, was people would run a simulation, and when the trainees were excelling and doing things really well, people had this thing in their mind of, well, it's not hard enough, I need to make it harder, right? So the patient who's getting the right care would end up in cardiac arrest or circling the drain and being really sick, rather than the script that is as written. And in fact, when you look at the simulations that we run the same ones many years in a row, and we run them almost identically each time, where they don't circle the drain unless that is exactly what they're supposed to do. Actually, the patients will have outcomes where you do the right thing, the patient will get better, if that's what we believe physiologically would happen to that patient. Because fidelity isn't just about touching things, it's actually about the physiological fidelity, and we want people to have those wins. It's hard to debrief a sim that goes well, really hard, but it's really important to realise whether or not it was serendipity that it went well, or whether it was really deliberate. And if it was deliberate, we want our trainees to speak to that, so that others who are observing know that, but also so that we can actually make sure that that can be a repeatable event. I am blown away. We usually take about 3 months for people to come back and be like, I wasn't expecting you to come out of, like, I was on a job and I was expecting you to come out of the woodwork, Claire, and because it was just like a sim. Every job that our students do, like our trainees do later, is actually more complex than any simulation they've had. But what we want to do is give them the tools over their training period, so that they have the tools to be able to grab and the building blocks to be able to work to do that. And I think what I want to make sure our trainees have is a positive experience. And that doesn't mean we pat them on the back and give them a gold star. What we want them to do is come out feeling like they can do this job, that it is achievable, and that when they think back on this process, it doesn't put them in the terror zone. It actually puts them in that really sweet spot from a challenge zone, and a challenge where they believe that they have this, which speaks to why we flipped the weeks. We used to do the pre-hospital week and then the in-hospital week. We now do the in-hospital week and build our teams towards some really big sick patients at the end.
Could I get you to speak to the clinical governance, Claire, from the training aspect? Because I think certainly working with yourself and as part of a high-performing team in London, and I'm sure this is the case in Sydney, there's themes that come through from the clinical governance that you can then bring back and integrate into the training as a general principle that maybe needs to be addressed fundamentally as a training principle. But could I get you to speak to how you inform training from the clinical governance?
Yeah, so very much like London, we've got a really robust system of clinical governance. All of our RSIs, the intubation, the laryngoscopy, is actually recorded and reviewed. We do M&Ms every month. We go through cases quite in detail, and there are themes, there are learnings from clinical work, but also from that coordination side of things as well. So as well as feeding back into our initial training program and our ongoing procedures and policies, we have a cyclic program as well. So we actually run all of our doctors and paramedics through training every 3 months, that we will integrate more things. And so we do feed our things that we need to learn into that program. So for example, at the moment, we're going back through non-invasive ventilation, delayed sequence intubation is one of the topics that we're running through with our teams at the moment, with some pre-reading, simulations, workshops, to make sure that we have a really solid understanding and really deep understanding of how to actually enact those procedures in a pre-hospital, in an inter-hospital setting.
Could I get you to speak to fidelity in simulation, Claire. So I think one of the aspects of Sydney HEMS, and certainly the part of the educational strategy, is to inject high fidelity simulation into training. But I think the more you do training, the more you realize that even medium fidelity simulation can achieve certain aspects. So there is adages of high fidelity simulation. There's also the nuances of, to your earlier point, and I really like this, is bringing real world clinicians into the simulation, because what that does is it mimics some of the non-technical skills and communication aspects into real life that you'll see, and you'll be interacting with very similar kind of people. Could I get you to speak to the adage of high fidelity simulation, also where the nuances lie, where you can increase the realism, but then sometimes you can draw back because there's just meta themes or meta principles you need to apply when you get real bang for your buck, versus when you just need some simple sim just to illustrate some simple principles.
So I think of sim in several different ways, and I think the fidelity that you really want to think about is the physiological fidelity. Yeah, so for the patient, you want to make sure, as I discussed, that what is clinically happening to the patient is what would clinically happen to that patient in real life, which means you in your head, when you're writing a sim, need to think about the mechanism of an injury, think about what's happening to the patient with their physiology, how the pathology of that will change, and what you then expect the clinical treatment to be. You also need to think of some of those other things of, if they don't do those things, what might happen? When will their blood pressure drop? When will their SATs drop? And occasionally, obviously, people throw a spanner in the works and do something you don't expect, but you need to learn to respond to that. So physiologically, for the patient, you need those components. You then need physical fidelity. And the physical fidelity, I think about in terms of equipment and environment. Our trainees all have training packs, which I reassure them at the start of the week are the one thing I will not mess with. So they look after their own packs. They are exactly the same as our operational packs, and they will come to that. And that is, to take a Tom Evans phrase, it's a bit like their lifeboat. It's the thing that's the same every time. The boat will stay the same. The packs stay the same. Their partner might be different. The environment they're going to go to is different, but that is their reassuring environment. And it teaches them the importance of pack checks. And I know you love a pack check. We all love a pack check in pre-hospital care. So that is one component for that. We try our best to have the rest of the equipment as close as possible. But obviously, the more closely in contact with it the trainees are going to be, the more real it needs to be from a physical standpoint. So we have that side of things. But then if the further you move away out of the hot zone, so the hot zone being what's around the patient and around your learners, the less real, for example, it needs to be, because your situational awareness begins to be focused really in on the patient and the sim that's in front of you and what is real. And so you need to work on those components for that. We might also create some physiological fidelity for the students themselves in their own physiology. They're going, as the week goes on, we start sending them to sicker and sicker patients. And when we're tasking them, we know that people's heart rate, particularly when they're in that early phase of training, the bat phone goes, your heart rate goes up. And so we do create moments where we make them run to get their heart rate up, or do burpees or otherwise, to hopefully create that level of realism for people, so that when they encounter that in real life, they actually start to understand how they might use tools that we discuss with them during training to actually bring themselves back into those situations.
I think that's powerful, actually, because like you said, it's really about controlling your own physiology, and that really does mimic and map onto reality. So certainly running from a helicopter with a medical pack before you get to quite a stressful situation. Claire, could I get you to speak to the way you approach assessment of candidates, and indeed, do you parse and separate it apart from technical skills to non-technical skills, and measure them on each? Or does each simulation have the ILOs, internal learning outcomes, achieved or not achieved. How do you kind of measure the metrics, and indeed certainly over time?
So we have a doctor and a paramedic that look at the team, and we really are looking at it as a team-based approach to how people are managing the actual simulation that's there. You can't separate that though from individual practice, but that is a more longitudinal event. So we look through people from their clinical and what goals they need to meet for managing that particular patient, but it can't be separated from the human factors. And in fact, retrieval, I don't think you can separate human factors, logistics, and the clinical at all. They intersect with each other quite nicely. So we use a FarmSat. Cliff developed those with me years ago. We still utilize that tool, and allows us to write things when people have or have not achieved them. And then we do, as consultants and paramedics, score doctor, paramedic, or flight nurse, depending on who's in the sim, and also a team score. And they get that score. To be honest, that paperwork is a tool for us to use for assessments. It's very rare that we have to refer back to it, because what we'll do is they have their sims each day. At the end of each day, we sit as a faculty and have a conversation around how people are going, so that we can provide them with mentorship feedback in order to help them progress through the course. In addition to those FarmSats and how they are interacting in simulations, our teams get scored on halo procedures. They have to be assessed on those. And again, we do a team-based assessment with individual components of that. And then our final exam at the end of the course, again, they get a team-based assessment for that. So it really is pushing forward what we firmly believe, which is the team approach is what is the right thing for patients. Of course, after they do that 2 weeks with us, they then go on to individual supervised practice, where they are working with for the doctors, they're working with a fully qualified CCP, or the paramedics are working with a fully qualified doctor and doing supervised missions where they get mission debriefs, they get feedback, and we work with them to make them the best that they can be. Because ultimately, we're really lucky. Our recruitment is such that we have experienced clinicians in their basic professions who are coming to work with us, and we have got recruitment pretty right, I think.
Claire, could I get you to speak to high-performing debrief? You mentioned it before about getting the team to the wider team to debrief, and I think that's absolutely key, because there's certain elements which will be missed by the pre-hospital HEMS team that the wider team will capture. Is there any models of high-performing debrief that you prescribe to, sort of the D3 model or the Delta Plus model, or have you bespoke your own model of debrief?
We've taken bits from lots of places about how we do debrief. The Pearls model is one that sits in my mind for that, and I'm sure you've heard of that. In fact, in the podcast Debrief to Learn, there's a really great episode that I'll encourage people to listen to that Walter Epic does. I think it's episode 7, but I'll confirm that for you, so that you can put that in the notes. But it really is around deepening people's learning, and elevating the conversation out of the sim that's just happened into application in real life. And I think that's really important to do. But when we involve those who are role players, for want of a better word, to describe those other clinicians who are in the sim, we make a point of telling them to make sure that they are speaking in the character that they are then, particularly for the occasions where you do have a confederate. For example, one of the consultants is role-playing a consultant doctor, but doing it in a way that is mimicking what they would do in the emergency department rather than in the retrieval setting. And we make a point of saying, if you are being that role player, you do it in a way that says, hey, I'm Claire, I am talking as the doctor in the room that was there. And then you speak to that, so that you can tell people about what they've said made you feel, or what they did made you feel. And I think that can be really powerful, particularly in a pre-hospital setting. If it comes from a road paramedic who has never met you before, who tells you that what you were asking of them was either too much or not enough is really powerful. And a good example of that that actually happens quite frequently for doctors is they'll be like, oh, I didn't want to overload the road paramedics who were on scene. So they're doing lots themselves. They're trying to put in the cannula. They're trying to put on the pelvic binder. They're doing tasks that are very much within the remit of a road paramedic. And they'll say, but I didn't want to overload them by asking them to do things. And those paramedics will turn around and be like, yeah, I was standing around doing nothing, watching you do loads of work. You could definitely have given me some more tasks to do. And they are trying to work out as well how to interact with that doctor. So it is a dual learning phase. And I think that's really important. And it's so powerful for that doctor to hear that they can give them more and ask more, particularly when they'll say, yeah, I'll tell you if I can't do it.
So Claire, as the training comes to an end, I know you've just had a cohort in August actually. At the end of the training program, do you sit down together within the room with all the trainers and kind of maybe debrief on what went well, what didn't go so well, and indeed sort of this continual improvement, adaptation of scenarios? One of the things I really like what you said is the fidelity of the physiology of the patient, and I think that's key. And then the other aspect to that would be the fidelity of the physiology of the clinicians by bringing them through and raising their heart rate, raising their, maybe putting them under a few environmental human factor stresses, just to make sure that there's continuity of performance. But I guess my question is, do you get into a room after the whole training program, or indeed the training cohort has gone through, and sort of reevaluate and see where there is any incremental improvement?
Oh, I would love to say it was at the end of the program. It's the end of every day. We actually go through the sims, the workshops of the day at the end of each day. So all the team goes home, all the faculty sit around, we chat about it. I actually make changes almost instantaneously so that we're not forgetting them for next time. So I've already got the folder written for next February, and we make those changes. And then Rob Scott, who is one of the co-leads with me, we will have further conversation, often when we're driving home, about what people said, knowing that we will take some things and leave others, knowing that it's a built-in design process. Our trainees are asked for their feedback. So there's a lot of feedback there on a daily basis. We do it at the end of the 2-week period. And then as well as that, because we are now having more of the state educators come and join our faculty, we have another meeting about 6 weeks later, where we, as the state-based faculty, so just the leaders from the different bases, will actually meet together to see if there's any changes that we need to make, if there are any global things rather than the minutiae. So each day is minutiae, and then it builds out from there. Obviously, our training isn't finished at the end of our 2-week induction period. We do the cyclic program. Our trainees have to do aviation training. They do their ride-along shifts, and then we do monthly education days after that. So there's lots of other training posts where we need to do things. And in addition to that, many of our trainees do the Associateship of Pre-Hospital and Retrieval Medicine. And so there's more things that we have to do with them through that. So there's lots to do.
So just before we come into land, Claire, on the interview, just a couple more questions. One would be around, you just have had a cohort in August go through, and we were just talking offline about how excellent the experience and indeed the cohort was, and I think that typifies maybe, just like you said, the selection process, and indeed some of the pre-briefs and the way you interact with the students. Could I get you to speak to any commonalities of not necessarily training issues, but of themes that you see in teams that is needed to be addressed, albeit technical or non-technical, that kind of elicit a better outcome, and maybe through the feedback, maybe through the debrief on the back end. But is there any common themes that especially from this last cohort, that you kind of needed to address or indeed re-engage with?
It's not even for this last cohort, it's for many of the cohorts we have. We usually have at least 1 or 2 people with quite significant imposter syndrome when they start. They have thought they wanted to be there for a long time. They are worried about how they're performing. They're usually performing very well. And so that probably is our biggest challenge, is people coming through nervous about how they're performing and really wanting lots of feedback. So things that we've employed to help them with that is actually making a point of having mentors appointed for them throughout the course, and making sure that they get some individualized feedback as well as the big group debriefs, and making sure that that feedback is 100% honest and 100% constructive. Because what we want to make sure is that the trainees know what they need to work on, but also know when we're thinking they're doing well. And so they can start to develop those things. And it is incredibly helpful for that, I think, from a self-development point of view. How do you do those 1%ers? What can you do? And as an educator, I think it's really important to have a deliberateness to your learning. And you can only do that if you're told what you need to work on.
Even in high performers, the imposter syndrome can be actually a real rate limiting step from a number of reasons, because there's a real counterplay between confidence and overconfidence and arrogance, certainly, but also underconfidence. And actually the performance lies somewhere in the middle, and the nuance is that actually the Dunning-Kruger effect is in play. You're not completely unaware and overconfident, but then you're not on the other side of the curve where you've got so much experience and you feel completely underconfident, but there's somewhere in the middle where there's lots to learn on a daily basis, and there's this continual feedback cycle, but you feel like there is some semblance of confidence. And like you said, it's articulating good practice, there's affirmation there for the right things, but as you said, it's bespoke, it's tightly aligned to the person, and it course corrects and helps course correct as they go. So like you're right, they're not guessing as they go, which I think is powerful. Claire, as we just finished, just one last question would be really around if you could just speak to, because there will be teams and indeed individuals listening to this that run high performance simulation and high performance education as part of PHEM systems and otherwise. Could I get you to speak just to some take-home messages, just to leave people that they could maybe apply or indeed think about as they progress through their training?
The number one thing for any simulation is actually keep it simple. And it is about how you make people feel. It's about giving them the appropriate level of challenge and not clouding the message that you want to give them. One of the things I most regularly have people come to me about sims is, oh, I just did this job and it's amazing and it would be just like a sim. And they start to tell me what the job is that they went to. And I'm blown away by how complex it is and how challenging that would be to not just run, but to have people believe that that could really happen, and then to debrief it after that. A great example is a patient who's fallen down a cliff, got a pneumothorax, and been stung by a bee. Like, you can't make that stuff up. So I do think keeping it simple and keeping your message simple and aligning it, knowing that simulation is part of a curriculum and you need to build the other building blocks around that. It involves the pre-brief, whatever that looks like, whether it is providing people learning packages beforehand, but also setting their expectations for running the sim, for what's going to happen in the sim, then running a good quality sim, and then giving plenty of time for a debrief. A debrief should be at least as long as the simulation, if not longer. And most people don't give that enough due and spend some time learning how to debrief. I definitely know that there are people who are out there debriefing who've had no debriefing training, and I can't impress upon people enough that it's a skill. It's a hard skill. It requires work and it requires deliberate practice. So find buddies, get someone to watch you debrief your debrief, and watch you debrief and then debrief that debrief, which is incredibly meta, but so valuable. And I know that our whole teams debriefing has gotten better through giving directed feedback, debriefing, and then really some deliberate skills that they can almost do themselves in that debriefing mode, which we can chat about at a later date.
Yeah, indeed. Listen, that's fantastic. And just to your point, just as we finish off, I couldn't agree with you more actually about actually there is, I don't think, enough education around teaching debrief. And one of the things when I was teaching various teams actually in a HEMS context and otherwise is actually it's more about being a facilitator and, like you said before, allowing the room to feed into the educational content for the team. So facilitating feedback from multiple areas and not being necessarily the authority. Certainly you can give perspective, but the pivot is being a facilitator rather than being the educator, so you can get the room to instruct the team. And actually that was one of the revelations I had, is it doesn't rise and fall on my experience. It's quite releasing actually as an educator, that you don't have to be the authority. You have to orchestrate the room to get their perspectives to inform the team. And actually that pivot is far more powerful because you're getting multimodal learning from the whole room, which is bigger than you, and it's informing their practice, which is, I think, a great place to be.
Look, what that does is it creates a light bulb moment for people. And it is really powerful if that light bulb moment comes from within the room rather than the educator saying that. One of the tricks that I do to facilitate those conversations is, if you can imagine, you kind of make a circle, and around that circle you put an X where people are sitting, and then sit and follow with where the conversation goes. And if it is very faculty-led, you actually end up like this, right? Which looks a little bit like a marijuana leaf. Yeah. And we all know drugs are bad. So that would mean that the conversation regularly just comes back. And if you draw that out, you will see that framework. If there's one faculty member, if there's two, you might see two marijuana leaves on top of each other. Versus if you have a conversation that bounces around, you end up with this mess in many respects that ultimately comes back to the faculty member who's facilitating the conversation being able to say, hey, from what I'm gathering, this is what I'm hearing. And then you can direct the clever question that leads people down to that pathway to elevating the conversation away from talking about what just happened there to what is happening, what could happen when you go somewhere else. And I think that's really powerful. Those light bulb moments of applicability for elsewhere are, to my mind, what SIM is about.
That's powerful. No, it is absolutely. And something just you said, just as we finish off, is you said it earlier, and I think this is absolutely key. It's that active listening and bringing, as a facilitator, active listening to what the wider team are saying, but also the feelings of the team themselves, the high performing team, the HEMS team, but getting, as you said, the learning from the room and feeding that back in, and then you're right, informing. And this is the nuance, bringing the right question from the room, from the feedback, to align with the ILOs, to align with the intended learning outcomes for that SIM. Stewarding the SIM to come back to a defined endpoint that you want, but that actually captures the learning from the room. And I guess it's a funnel, and it's bringing that funnel of information down to where you need it to be.
Yeah, look, and I guess the other side to that is when you're talking about a funnel, is actually one of the jobs as a facilitator is to think about how people are feeling, which is why our debriefs always open with, hey, how are you feeling? Yeah. And it's not just good, bad, or otherwise. It's actually digging a little bit deeper through those things to understand where people are at an emotional level, to know where that means they're likely to fit from a learning point, but also knowing that, you were earlier saying, you need to tell people whether they're feeling like, whether they've done good or bad. And so you're knowing where they are. As a facilitator, you need to judge how you're going to take them through an emotional roller coaster if they need to hear that they've not done something as well as they think they have because of that imposter syndrome. and have them walk away, even if they didn't perform as well as and you all agree they didn't perform as well as they had hoped they would, that if they were faced with that again, they can face it again, because we know that, Maya Angelou said it, right? People will remember how you make them feel. They'll also remember how a situation like that made them feel. And you don't want to have someone arrive to look after a patient who's been stabbed, having performed badly in a scenario at some point in time, and arrive and go into that decompensation mode from remembering that's how they felt in a sim. What that you want them to do is be like, oh, I wasn't as great as that as I thought I was last time, but I now have the tools to move forward in this. And I think we need to remember how you make people feel is so important and so valuable, and can really have a massive impact on that high performance of the team. And that's where that threat challenge is super important.
Yeah, thank you. Listen, thank you for the last hour. It's been fantastic just to chat and catch up. We'll put in the show notes the episode you mentioned, because I think it'll be super informative for listeners. But just thank you for your time.
Yeah, no worries. I'll also send you as well our structure that we use for debriefing. Thank you for having me. It's been really lovely to have a good chat.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.